Hey everyone, and welcome back to PS Platypus. Today we're going to be having a look at some anatomy, and this week marks your final week of thorax anatomy. So it's mainly going to be a lot of revision of concepts you'd have covered in year one and at the beginning of year two so far. And so let's get started with mediastinal spaces. So the mediastinum, if you remember, is the space located between both of your lungs. And if you're thinking about the boundaries of this space, just think about the rib cage that surrounds it. So obviously you've got your lungs on both sides, but it's bounded anteriorly and posteriorly by the rest of the rib cage, as you can see in the diagram. And if you think about the anterior aspect of the rib cage, that's going to be your sternum and the posterior anterior aspect of the ribs, whereas posteriorly it's going to be your spine and the posterior aspect of your ribs, as you can see. When you're thinking about the actual compartments of the mediastinum, I like thinking about the slices you take to actually get there. So the first important major slice is your horizontal slice, which is your sternal angle or your angle of Louis. And that separates your mediastinum into two major compartments, a superior and inferior compartment. And then your next slice, so you can see the angle of Louis there, separating into superior and inferior. And then from there, the next slice is your pericardium. Your pericardium actually further divides the inferior mediastinum into a middle one, which is containing everything inside your pericardium, so basically your heart, your anterior, which is everything in front of the pericardium, and your posterior, which is everything behind the pericardium. So that's all those slices and boundaries and what's roughly contained within them. And then to top it all off, we have our superior and inferior boundaries of the mediastinum. And again, very simply, they are going to be related to your rib cage. So think about the topmost part of your rib cage or your thoracic cage, which is your superior thoracic aperture. And the bottommost part is your inferior thoracic aperture. So that sort of nicely summarizes all those mediastinal spaces and how they're bounded as well. In terms of contents, again, we've had a look at this last year, so I won't labor on the point too much, but here's a little table and diagram that we used last year as well. Some important things to keep in mind is that, again, your middle mediastinum contains your heart. And one thing which is not shown as clearly on here, but which is important to keep in mind, is that your esophagus actually lies posterior to your trachea, but in front of your spine. So you have it like trachea, esophagus, and then your spine at the very back. This is something which will become clearer in the next few slides when you have a look at the other images. But for now, just know that it's not as it's shown in the image here. They actually superimposed on each other. All right, let's move ahead then and have a look at the autonomic innervation of the heart. So the reason we're going to be covering the autonomic innervation at all is that we're going to try and apply it clinically to what happens in heart transplant patients. So with that in mind, let's review some of the important anatomy. So as we know, the heart is a bundle of smooth muscle, and the rate and force of its contraction is controlled by the autonomic nervous system, which has two branches, a sympathetic and parasympathetic branch. The sympathetic nervous system, in terms of location, starts off with your T1 to 5 roots in the IMLCCs, which I think stands for the intermedial lateral cell columns. And then it moves out via the white rami communicans to your sympathetic trunk, and then from there exits and lands onto your heart to either increase the heart rate via the SA and AV node, and also increase stroke volume by making the cardiomyocytes contract with more force. And the parasympathetic nervous system, it does a little bit differently. So it starts up with the vagus nerve coming out of the brainstem, and then going down and innervating the heart. And it's going to play the opposite role. So it'll try and decrease heart rate, but it doesn't do as much in terms of stroke volume. Its main role is to decrease heart rate through decreasing the firing frequency of the SA and AV nodes. And the final thing to keep in mind in terms of completeness is the neurotransmitters and receptors involved in all of this. So again, sympathetic wise, you could have noradrenaline and beta-1 adrenergic receptors. And parasympathetic wise, you're going to have acetylcholine and M2 muscarinic receptors. So that's a quick revision of your autonomics of the heart. Another important idea to keep in mind is that your SA node, this is going to be a very important idea for understanding the clinical correlation. Your SA node by itself wants to fire at 100 beats per minute. It was designed to do so. However, when you're at rest, you're in your rest and digest mode, which means you're going to have net parasympathetic tone. So even though your SA node wants to fire all the way up at 100 beats per minute, you actually end up firing somewhere between 60 and 100 rather than at the 100. That's because, when you're sitting down, when you're at rest, the parasympathetic tone is kicking in. So just keep that in mind. And that also, again, makes sense because if I were to take your heart rate right now, just sitting in your chair, it's not going to be at that 100. It's going to be much lower because you're in your rest and digest mode. Just a little tidbit to keep in mind because that will explain what happens in transplant patients later on. All right. Another quick reminder is to understand where all these nerves sit in terms of where they're running and how they're running through the thorax. So if you have a look here, I've tried to highlight some of those in this diagram. So your vagus nerve, your sympathetic nerves, and your phrenic nerve are all highlighted here and colored in. See if you can do the same thing by having a look at the diagram here and shading it in for yourself. So you can try and figure out from these mess of nerves, which one is which. In terms of the vagus nerve, again, it's a parasympathetics that's going to be responsible for decreasing heart rate. And your sympathetics, they are not very well shown here because, again, they originate in the spinal cord and it's kind of hard to see where they're coming out. But you can make out the sympathetic ganglia right there. And so you can kind of tell where the sympathetics is coming from for that reason. And then you also have your phrenic nerve, which is not actually innervating your heart, if you remember. It's actually more so innervating the pericardium surrounding your heart. So that's its role there. And it's also going to go further down and actually innervate the diaphragm itself to give it some motor control. So you can control, breathing in and breathing out consciously. And it's going to exit out via the inferior vena cava hiatus in the diaphragm. It's also important to understand where these nerves lie in the anterior to posterior direction. It's very commonly asked and tested on. So just know that your phrenic nerve is going to lie more anteriorly as it innervates the pericardium. The vagus nerve will go more posteriorly. And again, this can sort of be remembered by the fact that your vagus nerve not only innervates the heart, but it will also innervate your gut, your GIT, and that starts off with the esophagus. So it's going to actually innervate the heart, sure, but also go backwards to innervate the esophagus and continue downwards to the rest of the GIT. And your sympathetic trunks, again, they're going to lie at the very back because they're on either side of the spine. And so that's how you can remember where things lie in that plane or in that direction. All right, now we come to the actual clinical correlate. So as you know, when you have a heart transplant, you have to remove heart from the donor and put it into the recipient. And in doing so, you would have severed all of the innervation that was associated with it. So immediately following a heart transplant, the heart's no longer innervated by the host, which means that they lose that autonomic control over the heart rate. And if you remember from the previous slides, normally the autonomic control allows your heart to fire at rest at a slower rate. So let me repeat that. So normally at rest, the heart receives more parasympathetic innervation than sympathetic, which allows you to have a resting low heart rate between 60 and 100 beats per minute. However, when you cut off all that innervation, you're losing that net parasympathetic tone, and that results in you actually having a higher heart rate than you would at rest with a normally innervated heart. So transplant patients actually have a higher resting heart rate because that parasympathetic tone is lost because the autonomic nerve supply has been cut off. Also, additionally, because you've lost your sympathetic component as well, the heart's response to exercise, which is to increase heart rate and to increase stroke volume, they're blunted because of that loss of innervation. And so you can imagine it's important for transplant patients to be careful when it comes to exercise. And that's the clinical correlation of denervation of the heart and how that results in a higher heart rate in transplant patients. All right, now we're going to again do a similar thing. So cover some anatomy and then cover the clinical picture. So we're going to have a look at the anatomy of the heart blood flow. It's important just to roughly know where heart flows through the heart and between the heart and the systemic and pulmonary circulation. So to recap everything, let's think about heart arriving from the body. So deoxygenated blood arriving from the body. It goes into your right atrium through the tricuspid valve into the right ventricle, through the pulmonary valve into the lungs, where it's oxygenated, and then it arrives from the lungs into the left atrium, through the mitral valve, through the left ventricle, out of the aortic valve, and into the body. So it's gone from systemic to the pulmonary and then back to systemic circulation. And that's a very important thing to keep in mind. And we're going to use that to understand how pulmonary emboli form and then cause trouble. So pulmonary emboli usually start off as deep venous clots in your lower limbs. And the reason for that is stasis is the basis. That's sort of a mantra you'll hear over and over again, which is that whenever, for example, blood is slowed down or static, it's easier for it to clot and coagulate. And this is especially easier in the lower limbs, further out where the blood is a bit slower. And so when these blood clots form, there's a chance that the clots can break off and travel up higher through the IVC over here. So they start over here in the deep veins of the leg, travel up through the IVC. And then if you remember, from the body, they're going to enter the right atrium, through the tricuspid valve, into the right ventricle, out the pulmonary valve, and then be sent to the lungs, where in the lungs, they're going to be stuck in the pulmonary capillaries. And what that means is perfusion to the lungs is now poor. And so that's what we call a pulmonary embolism. So that's where the clot has broken off and traveled, so embolized to the lungs and got stuck there. And that'll be a very serious condition, because that'll start to make the lungs become ischemic. And you're going to have things like shortness of breath, pain, and we'll be covering more of that in sort of clinical skills in terms of what signs and symptoms you can look for with pulmonary embolism. Next up, we're going to be talking about referred pain in your thorax. So as a reminder, referred pain is usually when you have damage to an organ or a viscus. Rather than you feeling the pain at that organ, you actually feel the pain at a different spot on the overlying skin. And the reason for it has to do with your body confusing the location of the pain. So the example that's given here is that, let's say you had damage to your heart, right? And that could be because of a myocardial infarction or some other reason. But if you have damage to your heart, the pain signals or the sensory signals from that are traveling up into your spinal cord. But rather than being interpreted as coming from there, it actually is interpreted as coming from the overlying skin of the T2, 3, 4, and T2, 3, 4 regions and T1 regions. And so you can see that here, where heart pain presents as diffuse pain over those dermatomes. Again, it would have been covered in the past, but we're just revising that very briefly. And on the right, you can see a summary of all the different pain referral patterns for different pathologies that pop up in your thorax and also in your abdomen. An important concept to keep in mind is that unpaired organs, so organs that only have one copy of them in your body, they're going to have central pain referral. So for example, your heart is going to have pain referral, which is felt centrally, whereas paired organs are going to have pain referral to their respective sides. So for example, paired organs like the lungs, where there's two of them, if you damage your right lung, you're not going to feel central pain, you're going to feel pain towards that right lung, which sounds simple enough and I guess understandable enough, but it's an important concept to keep in mind, especially because it will become incredibly relevant for abdominal anatomy and abdominal pain, where we're going to have a look at a number of different organs there, and some of them are paired, some of them are unpaired, and therefore that's going to affect the pain referral pattern. All right, so we're going to have a look at a number of organs and how they refer their pain. So the esophagus, again, it's a central structure. If there's pain in there, maybe from reflux or from some sort of impingement by neighboring structures, that pain will be referred centrally because it's a unpaired viscera. Whereas with cardiac pain, again, we've covered this in the past, but with myocardial irritations, that's where your muscles of the heart are being irritated. That's going to have pain referral, as we discussed previously, over the T1 to 4 dermatome because your brain is confusing the location of the pain. Whereas with pericardial irritation, the pericardium is innervated by your phrenic nerve. And so your phrenic nerve, if you remember, has nerve roots coming from C3, 4, 5. And so it's going to confuse the location of the pain is coming from the C3, 4, 5 dermatomes. So you're going to feel more so the pain in your shoulder and the upper arm region rather than in the T1 to 4 dermatomes. So that's an important thing to keep in mind as well. Pleuritic pain, that's where you have pain associated with damage to the pleura. Your parietal pleura is sensitive to pain, and it's innervated in a number of different ways. So you've got your costal pleura, so that's on the more lateral rib-facing side. It's supplied by intercostal nerves. The mediastinal pleura, which is the more medial side, which faces inwards, that's supplied by the phrenic nerve. The diaphragmatic pleura is the bottom part, which is in contact with the diaphragm. They're all supplied by different types of nerves, so that will also affect the pain referral pattern as well. We won't go over that too much. Let's move forward instead and have a look at an important clinical correlate, which is aortic dissection. Now, aortic dissection, you won't cover in too much detail this year, but essentially, as the name suggests, it's dissection or a tear in the intima layer of your aorta. And when you have that tear occurring, blood can enter through that tear and actually split apart the intima and media layers of your aorta. So you can have a look at that better in this diagram over here, where there's a slight rupture or tear in the intima, blood can enter and it can fill up that space. And you can imagine that that can obstruct blood flow because all the blood flow is being diverted away through there. But also there's potential for the blood vessel to rupture and all that blood to start bleeding out internally, and that can have devastating consequences. So you this year will learn about the impacts of impaired blood flow because of aortic dissection on the organs that are supplied by the aorta. So for example, if you have that dissection happening quite early on, you're going to have impaired blood flow to the coronary arteries. And again, that's going to be felt as myocardial ischemia and central chest pain because it's essentially ischemia of the heart muscle. If there's impaired blood flow to the head, you're going to have lightheadedness because your brain is not receiving as much blood. If there's impaired blood flow to the posterior intercostals, then you're going to have ischemia of the abdominal wall muscles, the posterior abdominal wall muscles, and therefore you're going to feel some back pain. And then also there's a strange thing that can happen where your blood can enter under the intima and start dissecting the aortic walls, but that dissection can actually travel upwards. So if you imagine the blood collecting here, you can actually keep going upwards and further dissecting the intima from the media, keep traveling upwards, and then eventually reach the heart and leak into the pericardial cavity. And you can have a look at diagrams of that online. But if that happens, it's going to start irritating the pericardium. And as you know, the pericardium is innervated by the phrenic nerve. There will end up being shoulder pain because of that, because of C3, 4, 5 dermatomes now being involved. And you can see that on the summary diagram, as a result, the aortic dissection actually has pain referral patterns that can pop up in the central chest, the shoulder, and the back, depending on where it's located and what it's impacting. All right, next we come to another important anatomical concept, which is esophageal constrictions. These refer to 4 natural constrictions that occur within the esophagus, and that's because of surrounding structures putting some slight pressure on it and making it a bit narrower at those sites. So the first structure that we have, which causes the esophagus to narrow, is up top, we have the cricopharynx up at C6. Then you have the aortic arch, and it's harder to appreciate anteriorly, but if you were to look from a lateral view, so from this side, you'd see the aorta sort of pushing from the left-hand side onto the esophagus and making it constrict from that end. And then if you go further down, you also have your left main bronchus or your left primary bronchus at T5. also causing some slight constriction of the esophagus. So again, C6, T4, T5, and then your final constriction is actually relatively easy to remember because you would have covered the hiatal openings of the diaphragm last year, is the esophageal hiatus. So that's where your esophagus is going to pass through the diaphragm. And because the diaphragm is a muscle that bounds and surrounds the esophagus, it's obviously going to constrict it a little bit there as well. And this is clinically important because if you imagine any of these constrictions becoming even greater, so if it becomes more constricted, or if some new constrictions form, maybe because of neighboring swelling or neighboring tumors, what can end up happening is you're going to have difficulty swallowing, and clinically we call that dysphagia. So that's it for anatomy. If you again have any questions, concerns, feedback, let us know in the comments or send us a message. This was primarily revision of concepts you would have covered in the past. So there wasn't too much new anatomy besides things like the esophageal constrictions. But I hope that all made sense, and we'll see you in the next one.